Hi everyone, my name is Pete and I did a little presentation on Hep A, C and E at work the other day, and I thought I might just record it and share it all with you in case it's helpful. So it's kind of pitched at maybe med students or junior doctors or anyone really, anyone who might get some use out of it. So I'm going to be talking about Hep A, C and E. I'm going to be asking a whole bunch of questions just to kind of keep you interested, keep your mind active while you're listening, take you through some of the history, and then answer some questions. And I'll probably split this up into a couple of parts because Hep C, there's a lot more to go through with Hep C. So I might just go through Hep A and E together because they're peas in a pod, essentially. They're very similar, except for pregnancy and immunosuppression. We'll get to that soon. But I think that's how I'll break it up. So there'll be two videos. So this is a Lego liver, and you can see the right and left lobes split by the ligament there, and the little gallbladder sneaking out the bottom. So questions to test your learning. These are true or false questions. Just keep them in the back of your mind as we're going through the lecture. All the answers should be in the lecture. So true or false? Hep A rates are rising in Australia with many chronic carriers. With an animal reservoir, it's commonly asymptomatic in those over 40. True or false? Hep E is rare in Australia and may be transmitted by blood that is associated with a high perinatal mortality that is not preventable by a vaccine. In Hep C, interleukin 28b state is the most important pre-treatment predictor of antiviral response, but does not influence disease progression or prognosis. The diagnosis of Hep C is made solely on the presence of anti-Hep C antibodies in the serum. True or false? And I also just want to make a special note. I've got a few slides here from like an Australian Doctor. There's an excellent article on Hep C on Australian Doctor. Just want to shout out to my homies, so to speak. But this lecture here by Dr. Lorenzo Rosario, he's a hepatologist at University of California, Davis. And if you just search for hepatitis C, UC Davis, you'll see his result here. Likewise, if you search for hepatitis E, Curo, you'll see the video here. And there's a few slides from both videos, and I just want to thank them for their excellent presentations. I hope they don't mind that I've used a couple of slides in my lecture here. So the history, let's go through it from the ancient times all the way through the 70s to 1989 with the use of reference vehicles at the time. So, where am I? Alright, so at the time, transport, they were using some chariots. So the Greeks and the Romans, they suffered from jaundice, or at least it was documented that way anyway. And Prometheus, he's a Greek titan, and he's depicted here in the Rubens painting. And he was, a friend of the humans, and he stole some fire from the gods and gave it to the humans to use. He also made us all out of clay. This is all according to the Greek mythology. And he's our best buddies, dog's best friend, man's best friend rather, not dogs. So he stole the fire, gave it to us, and Zeus punished him for this. He chained him to a rock, and an eagle came down to eat his liver every day. And this hints at the regenerative capacity of the liver that they probably knew about even back then. And maybe, just maybe, it's the first ever liver biopsy. Nowadays, we do a biopsy kind of like this, and note the lack of ultrasound here, which would be ideal. Would be gold standard. So in the 40s, a guy called McCallum, he's the first to use the term hepatitis A. It was previously described as epidemic hepatitis rather. And the whole nomenclature behind hepatitis is really when they were first kind of named, if you like. When they were first kind of discovered. So you'll see that Hep C was kind of discovered late, officially discovered late, but it was known about before D, so it was then called C, if that makes sense, in a kind of an orderly fashion. In the 40s, people might be driving around cars like that. Oh, and Hep B was called serum hepatitis, reflecting the kind of bloodborne nature of it. There's a lot of Australian heritage to hepatitis. In the 60s, we might have been driving around one of these classic Holdens. Is that an FJ Holden? I think so, not sure. The first surface antigen for Hep B was actually called Australian antigen, and was discovered in an indigenous person originally. Then, in the 70s, we got these big fancy things called scanning electron microscopes, and they became available commercially at least, rather than academically. And a guy called Dane discovered Hep B, the actual virus itself, even though it was known about prior to that as called serum hepatitis. He used a scanning electron microscope to discover that, and the actual paper of the title was Virus-like Particles in Serum of Patients with Australian Antigen-Associated Hepatitis, i.e. Hep B, as it was known at the time. In 73, the virus for Hep A was discovered under a microscope. And the most common strain, 175, was actually first isolated from the feces of a patient on the outskirts of Melbourne, amazingly enough, which is where I'm from. A bit later in the 70s, a clinical syndrome of hepatitis was described. It was known as post-transfusion non-A, non-B hepatitis, and that would later become known as hepatitis C. So you can see here that it was known of, but it wasn't known exactly what it was, but it was still described as Hep C because it came after the named A and B and before Hep D, that was just so happened to be named before Hep C became named. But Hep C was known about in an entity even though it had no name before Hep D. That's kind of confusing, I guess. Sorry. I hope that makes sense. So in 1977, Orezetto discovered Hep D. 78, Curo, maybe. I've written a question mark here because there's a bit of a debate over this, but I guess most people would credit Curo with discovering Hep E in outbreaks in the Kashmir Valley with high death rates in pregnant women. And it may have been described earlier in previous outbreaks, particularly in Delhi in 1957, but Curo was the first guy to really isolate Hep E in the serum. Hep C was kind of formally discovered in 1989, so relatively late when we're driving around Commodores like this. Alright, so that's the history, roughly. Hep A, like it's peeing upon Hep E. So what's the definition? Well, it's an acute viral infection that's caused by the hepatitis A. It's an enterovirus, and it's transmitted by the fecal-oral route, generally speaking, with complete clearing of the virus. Again, generally speaking, and it's vaccine preventable. So there's lots of genotypes. There may even be more than these three, but one is pretty much the only genotype in humans, accounting for the vast majority of cases. It belongs to this family of viruses called, I'm not sure if I'm saying it right, picornavirus. Pico means small. RNA is obviously RNA, and virus is virus. 7.5 kilobases, so 7,500 bases, or nucleotides make it up. And in the Baltimore classification of viruses, it's group 4. It's positive sense, so it leads 5' to 3'. Single-stranded RNA, it's non-enveloped. We'll go over this, what this means to be positive sense in the Hep C stuff. But just to show you quickly that Hep A is very similar to Hep E in that they're both RNA viruses, unlike Hep B. They're both non-enveloped, unlike Hep C and B. And they're both fecal-oral, unlike the rest of them. So they're very similar. The epidemiology of Hep A. So just a reminder on basic epidemiology. So you can think about it any way you like, but I think a good method is to think of things as rare, not uncommon, and common. So rare is under 50 per 100,000 in terms of incidence. So an example might be sarcoidosis at about 6 per 100,000, or Crohn's at about 15 per 100,000. Not uncommon, something you see, but not terribly often, is, for example, breast cancer about 100 per 100,000, or an upper GI bleed at about 100 per 100,000 again. Common is something you see all the time, like a neck of femur fracture, about 500 or so per 100,000, or age-adjusted, a STEMI at about 200 per 100,000. So how does that compare to Hep A? Well, it's pretty low here in Australia, about 1 per 100,000. So you could say it's rare. Surveillance data has existed since 1993, and it's declined rapidly, particularly with the introduction of vaccines, which I'll show you. So vaccines started in 1999 here in, well, not here, but up in Queensland. And I'll just quickly skip ahead here to show you that these are the notification rates in red and the hospitalizations in blue. So you can see that there was reasonably high levels until the Queensland vaccine program came along, and they dived. And then that was so successful that a lot of the other states, like South Australia, Northern Territory, Western Australia, they also introduced vaccines, and it dived even further to get to where we are now, which is pretty low. So it's mostly in Indigenous communities that Hep A is a problem. Although vaccination of travellers has also probably played a large role in this too. I just wanted to mention here about children having high incidence but less hospitalization. So this just shows you roughly in blue declining this way to this way, and roughly in red declining this way to this way. So this shows you the younger you are, the more notifications you get from that age group, but the less hospitalizations you get. And the exact opposite is true in the elderly. So the older you are, the less notifications you get, but the more hospitalizations. So you get sicker if you get this when you're old. You're more likely to get it when you're young, thankfully. So this just effectively shows the same thing in the kind of the brown line here and the pink line. That's males and females who are younger, and versus the males and females who are above 60 in this blue line, showing the number of notifications. Much less as you get older, but it's more severe. And again, that shows the vaccination rates. This just shows you a breakdown state by state. So it's, as I said, it's unfortunately a much bigger problem in Indigenous communities here. So it would make sense that you have many more notifications in places where there's more Indigenous people, like the Northern Territory or Western Australia, and lower in places like, say, Victoria. All right, what about the rest of the world? So the USA, they have similar rates, but and they've had similar success with their vaccine. I really like this picture. This is a really amazing pictorial representation of how dramatic the effect of the vaccine has been. So this is before the vaccine in the late 90s, and you can see more the darker the blue, the more reported cases per 100,000. And this is after 2006, after the vaccine. And you can see here that there's almost no blue at all. It's really wiped it off the face of the United States, really. Quite dramatic. But the rest of the world, it depends where you live. So this is seroprevalence, so not incidence, but prevalence in the serum. If you live in Africa, you're virtually guaranteed to get it at some point in your life. And or India or Pakistan. It's virtually universal there. Alright, so it can be common in those communities, but rare in Australia. The risk factors. So the risk factors are, the key one is really not being vaccinated is the biggest risk factor, I guess you could say. So just for example, there were 444 notifications for the year 2006-2007. Of those, vaccination status was reported in 169 of those 445. So of the 169, how many of them were actually vaccinated and how many weren't? So almost all of them, 162, were unvaccinated persons, and the remainder were partially vaccinated persons. Importantly, there was no report in a vaccinated person. So it's a pretty effective vaccine at 95%. You only need 2 doses, and it's generally only given to Aboriginal children here or Indigenous children in Australia. You can also get it if you're a traveller. There's a combined one with Hep A and Hep B that requires 3 doses. And you can test for immunity if you want, but it's not necessary because it's such a safe and effective vaccine that you could give it again if they had it. It wouldn't be the end of the world. And likewise, you don't even have to follow up with serology because it's so effective. So I'll just try not to make you too sick there, but I'll just show you here on this. This is the Australian vaccination schedule for children, and you'll notice that Hep A is kind of not required unless you're an Indigenous child, and particularly in NT, Queensland, blah 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 blah. So technically speaking, I guess if you're an Indigenous child, you don't need it in Victoria, but I guess it might be a good idea anyway. But that's what the schedule says. So the recommendation says that you should get vaccinated for Hep A if you're obviously an Aboriginal or Torres Strait Islander living in those states we just spoke about, or if you're a traveller going to, say, India, Pakistan, Africa, anywhere it's endemic, or if you have developmental disabilities. And this just reflects the nature that Hep A is prone to outbreaks in communities that have poorer hygiene, and that's thought to be people with developmental disabilities. Or if you have the likelihood of severe infection, so if you're already at risk, so just say you have Hep C, you're a transplant recipient, or you have some other liver disease, then you might get a much more severe attack of Hep A, so it'd be worth being vaccinated in that case. Or if you're at risk for any other reason, either occupationally, for example, you work with a lot of young children in Indigenous communities, or your lifestyle risk, for example, you're a man who has sex with men, or you practice intravenous drug use. So investigations. So generally, you can just do Hep A antibodies, and they'll hopefully be detectable by the time you get symptoms. Importantly, you'll be not congenital. You'll be contagious by the time you get symptoms and before you get symptoms. So that's partly why it spreads so rapidly. And the anti-Hep A antigen is detectable for months afterwards, and you pretty much get lifelong immunity with detectable IgG antibodies. LFTs commonly show transaminases sky high in the thousands. So this is just to show you that this guy here has got Hep A positive, so he's had that in the past. Clinical. So just as a rule of thumb, in general in hepatology, there's in a hepatitis rather, there's a bit of a rule of 80 and 20, 80-20. It's handy to keep that in your mind. So as a rule of thumb, 80% of children are asymptomatic, and the opposite is true for adults. Only 20% are asymptomatic. It can be broken up into 3 stages, the pre-ictal, ictal, and post-ictal. And I just wanted to point out here that you get fecal shedding of your Hep A, of the Hep A virus, before you get symptoms. So it's very important to know that. So ictal. Pre-ictal. So it's just generally malaise, a bit like the flu, fevers, nausea and vomiting, right upper quadrant pain, and apparently you get hepatomegaly in about 80% of cases if you're symptomatic. The big money here is in the ictal stage, so this will challenge me, see if I can remember all this bilirubin stuff. So you know that senescent red cells are phagocytosed by macrophages. In fact, why don't I just skip over that and try and explain it here in this pretty diagram. So this is from Guyton, an excellent physiology textbook that I've kind of hacked and written over the top of to make it a bit more explanatory. So your old red blood cells, after about 3 months or so, they get taken up by the spleen, and they get broken up by heme. So they get split into heme and globulin. So the heme gets broken down by heme oxygenase, or reductase as it's also called. Let me just check reductase. Yeah, so it's been a while since I've given this presentation, so sorry, I just want to check a few facts and figures. And that makes biliverdin, and then biliverdin reductase then converts that to bilirubin, which then goes to your blood bound to albumin, protein bound. And the amount of albumin that binds is obviously proportional to the albumin, and anything that might bind to albumin, like drugs. So that's a variable thing, but the important thing to note is that it's unconjugated. So it's lipid soluble, but not water soluble. So you can't just pee that out. It's got to go to your liver, where the bilirubin is bound to Z and Y proteins, and an enzyme called gluconeryl transferase gluconerizes it. Is that a word? Don't know, but it makes it conjugated so that it can be excreted in the urine or any water-soluble medium, but mostly the urine. And Gilbert or Gilbert's syndrome is a deficiency of this glucuronidase transferase, so you get an increase in unconjugated bilirubin. From there, once it's conjugated, it goes out the liver, it goes out into the bile, and into your colon, where, what have I got here? Yeah, so even though it's got here urobilinogen, so I've just got here, it goes into the colon, and then it gets acted on by bacteria, and it's not really written here, but there's a step in here that converts that conjugated bilirubin to stercobilinin. Here we go, stercobilinogen. Yeah, so it is in here. So it converts it to that, and it can also be converted to urobilinogen. Urobilinogen can be reabsorbed by the vasculature of the GIT to go back out the kidneys. It can be oxidized when it's exposed to air or by bacteria, and it is then converted to urobilin, which gives urine its yellow color. Stercobilin is colorless, but it's oxidized in the bowel and goes to stercobilin, which gives poo its brown color. Now, there's also this not very well documented unconjugated, or just enterohepatic circulation is really what it is. So you can actually just reabsorb this bilirubin, the conjugated stuff. I'm not sure why I put unconjugated there. But anyway, you can reabsorb the conjugated stuff back into your bloodstream, and it can keep on going. That's important in children with jaundice. But on this diagram, it might make sense why, if you have an obstructive or hepatic cause of jaundice, as opposed to like a post-obstructive cause of jaundice, like say you had a pancreatic head tumor. In the hepatic cause, you'll get pale stools and dark urine, because you get damage to the drainage system, so you can't drain it out this way. So you don't get this stercobilin going into the stool. You get reabsorption, and then therefore you get the whole pathway is geared towards this and not geared towards this. So you get dark urine, pale stools, because this kind of pathway is blocked. Hopefully that makes sense. So I'm just going to skip over this because it's basically what I've just said with that diagram. Hopefully that makes sense. So now I just want to reiterate what I just said about that damage. So this is a war zone, and you can see that in any war zone there's collateral damage. Transport gets affected in this city, for example. The same is true for liver disease. So even though you might say it's a hepatic cause of jaundice, so why should it be obstructive and cause that pale stools, dark urine kind of picture? Well, it's because of the collateral damage. So even though it's a hepatocyte problem here, you get collateral damage to the surrounding drainage of bile, and that's why. But you still get conjugation of the unconjugated bilirubin, because the liver has so much massive redundancy that you can basically conjugate but can't excrete. And the postictal phase, it's the recovery phase. You might get hepatomegaly for some time though, with some tenderness. So that's it clinically. Pathophysiology. So I'm just going to take you through here what happens. So you eat a delicious sandwich, unbeknownst to you, has a bit of poo in it. And you eat it, and it goes into your GIT, and it crosses over the villi and the epithelium. And then it goes, like all blood being drained from your GIT, through the portal system, into the sinusoids, into the hepatocytes here, dodging the Kupffer cells, and then it can go back out in the bile. It can be present in massive amounts in the bile. And just to take you back to the liver, here it infects the cell, and it's the lysis of the cell, the damage to the cell, that causes AST and ALT to leak out, and that's what you measure in huge transaminase elevations. And why does it even lyse? Well, it's actually not the virus, it's the cytotoxic response. So because there's a virus, there's foreign proteins in here, they'll be kind of like spewed out of the cell, if you like, on the MHC1 molecule, as depicted here, and circulating CD8 cells will recognize that as foreign and kill that cell. And it's really your immune response that's the damaging part here, not the virus itself. And you also excrete the virus in your bowel down the same pathways as we spoke about for bile excretion and stercobilin and bilirubin. And that's how it infects other people. So I just wanted to make sure I've read all this. So yeah, it's usually in low socioeconomic areas with poor sanitation. We don't really know why or how it's absorbed by the GIT. Incubation time, about a month or so, a few weeks. And they're contagious until about a week after. Yeah, alright. Moving on. So just to make that point again, that it's really the virus. Sorry, it's not the virus, it's the immune response that's huge, and maybe an overreaction, you could say. It's your own immune response that kills your liver. Transiently, of course. You do recover for the vast majority of people, but it's not the virus. There's no animal reservoir, although some might argue that primates can be reservoirs, but basically there's no animal reservoir. It's just the human intestine. It's relatively hardy, and it can actually stick around for quite a while. On your hands, it lasts for 4 hours, so you've got to wash your hands. Oysters, it can last for days, and on dried feces at room temperature. I think there's a study that how they work this out by asking a whole bunch of volunteers to handle poo, but it's a bit icky. It lasts for about a month, and you can actually get it in other ways. Like there have been reported cases of IVDU transmission of Hep A. You can get it in like anal sex, and you can even get it in vertical transmission from mother to baby, but it's very, very rare. So fecal oral is the big one, but it is possible to get it other ways, although very rare. So treatment, well, you don't really have to do anything. Your body will fix itself just like it damaged itself. So you just have to support them really, and that's mostly with rest and some fluids, IV if you have to, and avoiding hepatotoxics, so principally alcohol and paracetamol. You can treat people symptomatically for their fevers if it's a problem for them with some ibuprofen, but not some paracetamol. We're trying to avoid that. And you can give antiemesis if need be. So what's the prognosis? Well, it's very good. Almost all patients have a complete recovery clinically and biochemically within a few months. And the transaminases generally do return to normal earlier than the bilirubin. And you get lifelong immunity for your suffering. Mortality is quite rare, under 1% develop fulminant hepatitis. And the risk factors for poor outcome are basically what we spoke about before. So if you're old, you're more likely to get a severe case, or if you have hepatitis. Particularly, say, Hep C. There was a study here, it's not that well studied, but one study looked at a prospective study of Hep C sufferers in the long term, and looked at a subset that got Hep A, and there were only 17 of them. And of those people, 6 died. So that's a pretty high death rate for what most people is a very benign thing. So if you have Hep C, you've got to get vaccinated for Hep A. Alright, peas in a pod. Hep E, the other one. So what's the definition? Well, like Hep A, it's an acute viral infection caused by the Hep E enterovirus, usually with a clinical course that's pretty similar, but maybe a little bit more delayed, but pretty similar to A, with fecal oral transmission, with complete recovery in most people, but there's 2 major exceptions here: immunosuppression and being pregnant, where it may be fatal for both baby and mother, especially in the 3rd trimester. And we don't really know why. So like Hep A, there's a whole bunch of genotypes, but it's probably a bit more diverse with Hep E. So genotypes 1 and 2 generally thought to be from developing countries, and 3 and 4 generally from industrialized countries. Like A and C, it's a positive sense single-stranded RNA virus. It's non-enveloped, and it's of a debatable family. So it's either this one or this one. Now, I'll have a go at pronouncing this. So Calicia Verde, whatever. It's either from this one or this one. and it's a relatively similar length. And epidemiology. So it's like the evil little brother to Hep A, and then it's can be more severe. It's less prevalent. So generally, Hep A is more virulent, more widespread than Hep E. There's much more limited data on Hep E, unfortunately. So there was one seroprevalence study in Iran, hemodialysis patients who you'd expect to be high risk, and there was only 7.4 seroprevalence in that study. In Egypt, another study showed about 50% prevalence. So who really knows? It's generally not a chronic condition. It's mostly reported in outbreaks in third world countries, as I said, first described in the Kashmir Valley. And the incidence is so low in the US that a single non-travel related case became a case report, although the patient did have HIV as well, so maybe that was it. In the UK, there are, where there's like 62 million people, there were only 28 cases of locally acquired Hep E between these 2 years. So only 28 locally. Of course, there were probably more that were caught elsewhere and brought back to the country, but locally acquired is quite rare. And this is just to show you a little the explosions in the third world. Not third, developing world, I should say. But so you might think that it's quite rare in the developed world, but that might not be the case. There was a big study, say 19,000 patients in the US, that found a 21% seroprevalence rate. So it's probably a lot more common than we think. And there's been a few points made about this. Maybe this is because it's mostly genotype 3 and it's less symptomatic, so maybe people are getting it and not realizing it in industrial countries. This is a really interesting little graph that's made with data from the Victorian Infectious Diseases Reference Lab. So what they did was plot outbreaks in India and put them against outbreaks in, well, when I say outbreaks, I mean small outbreaks here in Victoria. So you can see that the number of reported cases is pretty darn low. There was a spike here in 2004 of 10 cases. So they looked at these cases and they found that 9 out of the 10 had returned from endemic areas that with travel dates that match the kind of 2 to 9 week incubation time, about a month or so incubation time for Hep E. And of those 10, 7 were actually from India. So it's probably a lot of travellers coming back, bringing Hep E with them. And I just thought this kind of surveillance data was interesting. It's kind of unrelated, but I thought I'd mention it. Google Flu Trends. Google Flu Trends is a product that works by, they track search terms in different areas and are able to kind of predict flu outbreaks. And they've looked at it long term, comparing it to CDC data, so referrals or data from doctors in the area, and it pretty much exactly matches it. It's so accurate that it got in the news recently because it actually over predicted it. So it was in the news because it was actually inaccurate for once. So I think that's kind of interesting. Risk factors. So as for A, but with one notable addition, being pregnant, particularly if you're in the third trimester. So how do you transmit it? So, about a month of incubation time, fecal oral route, contaminated water is the most common thing. You can technically get it cross species, so there have been reports of pigs and infected meat, including deer, spreading it to humans. Transplant is a big one to think of. So about 5% of solid organ recipients in a French study received Hep E. So can you get it other ways? Yeah, you can, just like Hep A. So you can get it from blood. You can get it direct human to human. What have I written there? Direct human to human. Uncommon but has been reported. I think I mean like other than fecal oral. Perinatal. So there's limited data on this, but the limited data that we do have suggests that it's very, very bad. So there's a Lancet report of 8 babies born to mothers infected with Hep E in the third trimester. 6 of the babies had Hep E, 2 died, and 1 of the 2 that died had massive hepatic necrosis. So it's if you just look at that study, I guess you'd have to conclude that it's easily vertically transmitted with major morbidity and mortality for neonates, unfortunately. So how do you prevent it? Well, it's just like A, sanitation is the most effective method. But unlike A, where there's not a vaccine. Did I say that Hep A had a vaccine? I should have said Hep A has a vaccine, but Hep A does not have a vaccine that's widely available. It actually does have a vaccine. So one was developed by GlaxoSmithKline in collaboration with the US Army. It was reported in NEJM in 2007, but it never came to market, and people believe this is because there was no real monetary incentive, because places where it's common are poorer places that maybe can't afford to pay, whereas places where it's rarer or less of a problem in industrialized countries, it's not a problem. So China actually in 2011 developed a vaccine, and they use it in their high risk populations, like their army. And some people, like I think there was an article in Nature on it recently, have suggested that this could be an interesting area for China and the developing world, that China have a vested interest in a lot of these developing world diseases. So it might actually bring a lot of benefit to the developing world. That's something to keep your eye on. So the clinical situation is very similar to A, just maybe a little slower. So I've just kind of superimposed E onto A here. So you can see that just like A, you're infective before you get symptoms, and it's about a month or so of incubation time. Lasts for a few weeks or so, and the major exception is pregnant women, where you can get very bad stuff. So pathophysiology, it's as for A except for two key concepts. So chronicity is one big thing in Hep E. So like A, Hep E is considered acute only, except if you're immunosuppressed, basically. I know I've written here transplant and immunosuppression, but really it's just immunosuppression. Transplant is kind of part of that immunosuppression, I think, anyway. A French study showed that 5% of all these transplanted patients developed Hep E infection, and half of those went on to develop chronic Hep E with persistently elevated viral load. So how do you treat that? Well, it's a developing area, so we don't really know for sure, but if you can trial them on a reduction of the immunosuppression, that would be good. Or you can treat it like Hep C, actually. You can use ribavirin and peg interferon. And we'll get to the Hep C treatment a bit later. So pregnancy, this is the big one. I just wanted to cover this in particular. So pregnant women are more likely to get Hep E in the first place, but they're also more likely to have much more severe consequences. So more likely to get it, so maybe 20% versus 2%. And they're more likely to have mortality, especially in the third trimester, where the rates can be as scarily high as a quarter to half of all women, which is pretty crazy. Why does it happen? Well, we don't really know, but there's a few theories out there, and a lot of the theories depend on the natural course, the relationship between hepatic failure and fetal failure, hepatic fetal failure and hepatic maternal failure. So sicker babies are associated with sicker mothers. Is this cause or effect? Are babies making the mothers sicker? Not sure. Mothers who deliver earlier do better, and this might suggest a kind of placental origin. So here's a few slides from Kuro's presentation, just kind of tabulating his prior research that just shows that in the third trimester, about half will have a fulminant hepatitis. This is acute viral hepatitis here, I think. And this study, a lot smaller numbers, but still, it looked at pregnant women that got Hep E versus getting non-Hep E, and looked at how many of them then went on to fulminant hepatic failure. And around half of them did for Hep E, and a very small amount for non-Hep E, so Hep A, for example. How does this happen? Well, this is one theory, mirror syndrome. So mirror syndrome is a different thing, but it helps explain the pathophysiology. So you probably read all about mirror syndrome, where there's a kind of a fatty acid synthesis problem. So usually you need a whole bunch of genes to make fatty acids correctly, and if you're homozygous for the gene that has a messed up fatty acid synthesis, so you make a dangerous fatty acid if you're homozygous for it, so you've got a gene from both your mum and your dad, you got the bad one from both of them, then that can mean those fatty acids can cross the placenta, go back to the mother, and destroy her own liver. And they think that might be happening with Hep E. So just to spell it out for you, you get Hep E in a pregnant female. You vertically transmit that to the fetus, and it causes it might have been fine in the pregnant female's liver, but it's not so fine in the fetus's liver. So that makes a whole bunch of toxins that cross the placenta, go back to the mother, and give her fulminant hepatic failure. Who knows? So that's Hep E. So I think I might just leave it there, and we'll go on to Hep C in the next video, and I'll do the questions and stuff in that video.